So our next presentation, it's my pleasure to introduce our next speaker, Dr. Bernhardi. He completed his PharmD degree at the University of Buffalo. Then he came here to University of Maryland Medical Center to complete his PGY2 Pharmacy Residency. He then moved on. He then stayed on to be our PGY2 Cardiology Pharmacy Resident this year as well. So sorry, we're just right. Thank you. So the title of this presentation for today will be on beta block party, inviting the inotropes. And then just remember, we're going to be still using the Slido, so the same hashtag as you were using for the first half of the presentation. Thank you. With that, I'll give it over to Dr. Bernhardi.
Let me just start this. Okay. So thank you for that introduction. I'll just jump right in. So as far as disclosures, I have nothing to disclose. I have no actual potential conflicts of interest for this presentation. As far as learning objectives today, so some of the things that I'd like to talk about today are comparing and contrasting adrenergic beta receptor pharmacology in the setting of heart failure with reduced ejection fraction, being able to list at least 2 hemodynamic alterations due to pharmacodynamic interactions between beta blockers and inotropic agents based on a review of the literature. And then by the end of this presentation, I'd like for us to develop an evidence-based pharmacotherapeutic plan for a heart failure patient with reduced ejection fraction on a beta blocker requiring additional inotropic support. So I have here listed, this is kind of a slide for your reference, some of the hemodynamic measurements that I'm going to be talking about today. Again, this is just throughout the presentation, I may have some abbreviations, and this is kind of just for your reference to look back at. So jumping in right with a case, this is our patient J.E. He's a 61-year-old African-American male with non-ischemic cardiomyopathy, hypertension, and atrial fibrillation. He presented to the emergency department with shortness of breath, lower extremity swelling, and a noticeable significant weight gain over the past few weeks. Physical exam was noted that he had a S3 Gallup heart sound present, as well as a JVP of 13 centimeters. And the team noted that he was warm and well perfused. Some of the vitals and pertinent labs I have listed here, and it helps kind of portray this picture of a heart failure patient. He has an NT-proBNP of over 13,000, and his chest X-ray showed bilateral edema and cardiomegaly. I listed here also some of his current home medications, and this is after a thorough MedRec had been done in the ED to confirm that these are the medications he was on chronically at home. Of note, he was on carvedilol 12.5 milligrams twice daily. So the first question, J.E. is having this episode of acute decompensated heart failure, and the resident on the team asks if his home beta blocker should be continued in the setting of being fluid overloaded. What would be the most appropriate way to respond? All right, so it looks like a lot of people were saying to continue as beta blocker. So continuing or stopping beta blockers, and we'll kind of go through some of this. So as far as continuing, discontinuing, or reducing the dose of beta blockers, there's a bunch of data out there, or various data out there that says that there is a benefit to continuing a beta blocker. These are some of the trials that I've listed here. There was a post hoc analysis that showed actually that withdrawing or even dose reducing a beta blocker had higher incidence of mortality compared to continuing. The optimized HF trial showed that there was an improved length of stay as well as discharge mortality at 60 to 90 days in this continuation group as well. And that one of the big things is that the percentage of people actually on the beta blockers at that follow-up was significantly higher in the continuation group versus somebody who was withdrawn. The withdrawn group was 56% of the patients at 60 days were not on a beta blocker, as opposed to the continuation group was greater than 90%. And then the Be Convinced study, this was a prospective trial that looked to show that it's safe to continue a patient on a beta blocker in acute decompensated heart failure versus interrupting their dose for 3 days. they saw that there was this benefit with being at long-term target dose within that 60-day to 90-day follow-up. Some of the guidelines on this issue. So in 2013, we have our heart failure guidelines, and they recommend that guideline-directed medical therapy, which includes beta blockers, to be continued in the absence of hemodynamic stability or other contraindications such as symptomatic bradycardia, any end organ dysfunction. And then more recently, actually, that published just this month online, the 2019 ACC Expert Consensus Pathway of hospitalized heart failure patients. And this is really important because we don't have a lot of guiding literature on this topic compared to a lot of the other things in our clinical specialty. And what they say is kind of mimics a lot of the other guidelines in the past, saying that unless signs of hypoperfusion are present, beta blockers generally should be continued in acute decompensated heart failure. And that if patients are actually refractory initially to their diuretic regimens when they come in for acute decompensated heart failure, it can be reasonable to have the dose. That kind of goes against what some of the earlier studies were, but again, that was just a post hoc analysis, and it's kind of a general practice that it can be possible to have their dose. And then beta blockers should be discontinued if inotropic therapy is needed or considered. And this is something that needs to be stressed, is that when a patient comes in and is needing an inotrope, their beta blocker should be stopped beforehand. So going back to our case, the team took our recommendation of continuing his beta blocker, carvedilol, and also starting him on IV furosemide as well. He was not responding to the diuretics as they had hoped, so they wanted to get a pulmonary artery catheter to further assess his hemodynamics. And on his right heart cath, this is what they found. Based off of these numbers, and these are kind of for your reference, based off of these numbers, and I've highlighted some of the more important ones, the team is considering starting an inotrope. So why are they using an inotrope? What's the reason for it? I have here listed 4 of the subsets that are generally known with acute decompensated heart failure. And the way they're described is whether the patient is warm or cold and wet or dry. So if the patient is considered cold or if they have low perfusion, they generally have a cardiac index of less than 2.2. And then if somebody is wet, they usually have a pulmonary capillary wedge pressure of greater than 18. Where inotropes really play a pivotal role is in this subset for these patients that are cold and wet. They can potentially be used in some of the patients that are a little dry as well, but for the most part, they're really used in this population. And that's how, if you look at our cath numbers, our patient falls into this subset. So I want to talk about also a little bit about the mechanism of action of inotropic agents. So we have the 2 more common pure inotropes that we have are dobutamine and milrinone. First, in our heart, in a cardiac myocyte, the way a normal physiology is, when a cardiac myocyte needs to be contracted, there's a stimulation of their beta-1 receptor, and it activates adenylate cyclase to create an increase in cyclic AMP concentration within the cell. That cyclic AMP then, through various mechanisms, causes an increase in intracellular calcium, and that intracellular calcium causes an interaction between actin and myosin to produce contractility of the cardiac myocyte. There is also phosphodiesterase 3, which is an enzyme within the cardiac myocyte that actually regulates some of this cyclic AMP concentrations as well. And this kind of regulates just how often the cardiac myocyte contracts. So with dobutamine, dobutamine is a beta-1 agonist, a beta-2 agonist, and also has some alpha-1 agonist activity as well. Dobutamine, for contractility, primarily binds to the beta-1 receptor and kind of mimics this normal pathophysiology, this pathway that happens. With milrinone, however, milrinone is kind of a different pathway. They inhibit phosphodiesterase 3, which inhibits reduction of this cyclic AMP concentration within the cell and producing contractility of the cardiac myocyte. So what happens after actually stopping our beta blockers, right? Is this beta block party, is it over? And when needing an inotrope, we need to consider the actual clinical status of the patient, as milrinone is renally eliminated, and if and what beta blockers were used previously. I have data here looking at metoprolol and carvedilol. And one of the big things that we kind of know with metoprolol and carvedilol, metoprolol tartrate has a half-life of 3 to 4 hours. However, the duration of effect of metoprolol succinate, which is the extended release, is 24 hours. And carvedilol has a 12-hour half-life, and that's usually why it's a twice-a-day drug. The receptor activity between the two is that metoprolol is a beta-1 selective agent, and carvedilol is a beta-1, beta-2 agent. And it does have some alpha-1 blockade as well initially. I have an asterisk here because over time, this alpha-1 receptor activity does dissipate with chronic use. What's also really interesting is that their effect on beta-adrenergic receptors. So metoprolol causes this upregulation of beta receptors, whereas carvedilol really doesn't have this effect. And that'll come into play as I kind of talk about more of the hemodynamics. So just kind of hold on to that. The stroke volume index between the two over time improves in metoprolol and carvedilol. And then systemic vascular resistance, there really is no effect between either of them on systemic vascular resistance that by the end of this study that was done. However, in the beginning of the study at baseline, carvedilol did have an effect on systemic vascular resistance, only kind of going to that point of that alpha-1 blockade kind of gets lost over time. So the hemodynamic effects and how these beta blockers interact with our inotropes that I've kind of talked about already. So normally when we give somebody an inotrope, either dobutamine or a phosphodiesterase 3 inhibitor such as milrinone, this is kind of some of the effects that we have on our hemodynamics. When we add metoprolol, there is a bit of a different effect, some key differences that happen. When we add dobutamine, there really is not, even though metoprolol is a beta-1 blocker, it doesn't really have an effect on the cardiac index, and that's because metoprolol has this upregulation of beta-1 receptors, and dobutamine is not necessarily too affected from a standpoint of causing more cardiac index or less. There is somewhat of an effect on pulmonary capillary wedge pressure, and then in phosphodiesterase inhibitors, there's actually an enhanced effect of cardiac index if metoprolol is on board and we stopped it and started milrinone. Carvedilol is very different. When we have a patient who's on carvedilol, after we've stopped their medication, if we're thinking about starting an inotrope, dobutamine actually has almost this blunted response of increasing cardiac index. There is an increase in cardiac index, but it's dose dependent and requires higher doses to achieve that. And also what's kind of interesting, as I mentioned before, carvedilol has activity at beta-1 and beta-2 receptors, and it loses alpha receptor over time. And dobutamine is active on all three of those receptors. So because carvedilol blocks beta-1 and beta-2, the only open receptor essentially is alpha-1. And dobutamine almost produces this vasopressor-like effect, increasing MAP and increasing pulmonary capillary wedge pressure. Again, similar to metoprolol, carvedilol also has this kind of enhanced effect on cardiac index. So kind of take-home points from all of those hemodynamics. For patients who have been receiving beta blockers, pharmacokinetic and receptor profiles should be considered before initiating an inotrope. And if you are initiating dobutamine, if they were on carvedilol, you might get this blunted increase in cardiac index and potentially even a vasopressor-like effect. Metoprolol is kind of unaffected. If we gave metoprolol and we stopped it and we give dobutamine, this cardiac index, you really wouldn't see an effect. You might see a reduction of the response in pulmonary capillary wedge pressure. And then for either of the beta blockers, if you stop them and then give milrinone, you may see somewhat of an enhanced increase than you'd normally see with milrinone itself. So question number 2. So the team determined that JE is in this cardiogenic shock after seeing those CAP numbers. And now they're asking you if what recommendations you would give for an inotrope. So what recommendation, knowing that he also, his last dose of carvedilol, 12.5 milligrams, was actually given 2 hours ago, and his order has been discontinued this morning. All right, so it looks like a lot of people are picking milrinone, and I think I would agree with that. So after 6 days of inotropic therapy and continued aggressive diuresis, JE has now significantly improved. His serum creatinine is back to baseline of this 1.1 to 1.3. His blood pressure is back up to where he was, and his cardiac index is now 2.2. So it's a lot. He's much more improved. These are some of the medications that he's on now, and of note, he has had some changes. Of note as well, he is currently being worked up for transplant, which is why his rivaroxaban was switched to warfarin, and he was unable to get a LVAD. He was denied an LVAD as he has been shown to have right ventricular, biventricular failure on echocardiography. So the team attempted to wean off his milrinone late yesterday, but the patient was unable to tolerate coming off of his inotropic support. And one of the new residents was inquiring about using a beta blocker 12 hours before discharge with close follow-up based off of what she had read on UpToDate. She comes to you with this question. So I want to lastly talk about restarting a beta blocker and kind of when and how we do it. So there is this great trial, the IMPACT-HF trial, and this is kind of predominantly what this resident was talking about. They looked at pre-discharge carvedilol initiation in stabilized heart failure patients. The patients, the percentage of patients treated with beta blockers at 60 days was their primary endpoint. And what they found was that there was a lot more patients who were continued on, they were still on their carvedilol at 60 days versus those who weren't given this carvedilol before discharge. Patients were ineligible for the study if they were class 4 decompensated class 4 heart failure requiring any inotropic support at randomization. And they were actually able to receive carvedilol up to 12 hours before discharge. So this potentially could be helpful, but in our patient, it doesn't really apply. These were more stable patients. They were off inotropes at the time, and our patient's having kind of some difficulty with weaning some of our inotropes. So while this is a great study in itself, it's not necessarily what we'd want to apply to our patient. And we'd let the resident kind of have them understand that. 2019, this expert consensus guidelines say that use of inotropes during hospitalization buy you longer periods of observation before you even think about starting beta blockers. And also, if you have patients who have actually been really difficult to wean inotropes, a lot of times some of this stuff kind of gets put more to be on when they become stable after discharge, because it does take a while for these patients to sometimes become stable. So the concomitant use of beta blockers and inotropes, and can it be done? So there is some data out there. It's quite old data from 1998, but there was a study with 30 patients with heart failure with reduced ejection fraction, and they looked at the combination of a beta blocker and a phosphodiesterase inhibitor. And in this study, they used enoxamone, which is essentially oral milrinone. They did a 5-step protocol. So the way that this study was conducted was patients who were this class 4 heart failure, they were given and stabilized on oral enoxamone. After that, they were optimized on all their guideline-directed medical therapy, which is predominantly their ACE inhibitors. From there, they were instituted on a low-dose beta blocker. And then from there, they were trying to wean off the enoxamone and see if they could tolerate that. And if they were not able to tolerate that, they had them on this long-term therapy of both. What they found was that there was an overall survival at 81% estimated overall survival at 1 year, and there was a lot of significant improvements with left ventricular ejection fraction, improvements in heart rate, and a New York Heart Association functional class. So what they kind of pulled from this is that even patients with very late stage heart failure, this could potentially help people who need to essentially bridge to a beta blocker therapy who wouldn't be able to tolerate initiation of a beta blocker therapy by themselves because of how unstable they are. This also is really important because it could potentially attenuate some of the unwanted effects from some of these inotropes that we have. So patients who inotropes can cause some arrhythmogenic events, and this could potentially hold some of that back. And while this study was done early on, a lot of these patients, they were able to somewhat make it to transplant. So this potentially could just kind of keep a patient stable enough until they got to that point. So some take-home points for the initiation of beta blockers. 2013, initiation of beta blocker therapy is recommended after we've optimized kind of their volume status and we've gotten them off of all of their intravenous diuretics, their vasodilators, or inotropic agents. For patients who are end-stage heart failure or unable to wean off this but otherwise are clinically stable, we can potentially carefully add on a beta blocker as it's shown improvements in left ventricular ejection fraction, heart rate, and New York Heart Association functional class. There is potentially some theoretic benefit in reducing the inotropic-induced arrhythmic events. And again, though, this is done, there's a lot of pre and post observation that needs to be done before initiating this beta blocker. So question 3. Given this new intern's recent inquiry about starting the beta blocker, what would be the most appropriate plan to suggest? So it looks like a lot of people would agree that we really need to discuss this timeline and decide some of the risk factors about initiating and deciding whether we want to start beta blockers inpatient or outpatient. But it's a discussion that needs to be had. So just kind of wrapping up the party, these are some of my recommendations from all of this. So for beta blocker discontinuation in acute decompensated heart failure, it is very crucial to assess for adherence of beta blocker therapy, so I can't stress enough a good med rec. Signs of any cardiogenic shock, symptomatic hypertension, and symptomatic bradycardia. Barring none of these things being an issue, we should continue our beta blockers. And then recommendations for inotropic management. Prior to starting any inotropes, we should stop beta blockers. And then the choice of the actual inotropic agent that's used really depends on some of the previous beta blocker therapy that they've had and any clinical status that's relevant. And then lastly, recommendations for concomitant inotropes and beta blockers. Adding a beta blocker for a patient that cannot sustain end organ perfusion without an inotrope can be done, but it is a very difficult process and it requires a lot of observation and making sure the patient can tolerate all these things.